Hello. We okay? All right. Good afternoon, everyone, and thank you for joining our learning series for the Canadian Primary Care Research Network. My apologies for the late start. We're just letting people filter in. I think we've got a good number of participants already, and I just need to pull up my slides. So today we're going to be talking about integrated care, and we have. My name is Sunil Bhattacharya. I'm a family physician and clinician scientist at the University of Toronto, and the co-chair of the Canadian Primary Care Research Network. Let me just sure I can get my screen to go. Here we are, share. And let me just pull this up. All right. Can everyone see which section are people seeing? The viewer or the presenter mode or the
No, the wrong one. The wrong one.
We're seeing the wrong one. Okay. Now we're seeing the right one?
Yeah, we're noticing the right one now, yeah.
Okay, excellent. So today's session is on care integration for people with complex needs and understanding the challenges and the paths forward. So I'm going to give a little short intro, and I'm going to hand off to our distinguished speakers. And so I'm going to start us off. So, we are a primary care community, but we have people who are interested in people with complex needs, and the specialty community are really part of that. And so for today's session, I've invited Paul Ronksley and Terence Tang, who I'll introduce more fully. But two people who actually, practice specialty medicine or do more studies in the specialty side to help us understand the various things that we need to do to provide comprehensive care. I'm going to start by taking us back to 2011 to a paper that in the New Yorker, not a medical journal, but a widely read journal by Atul Gawande, that highlighted this idea that there are a subset of people who account for a high proportion of clinical costs. There's a rather insensitive photo here of someone that I think was dubbed $1 Million Murray, and in the era of patient-centered care and patient-partnered research, we probably wouldn't be using these kind of images. But I want to take you back to where we were, the beginning of this, which was essentially the idea that about 1% of patients generate or account for 50% of health system costs, and 5% account for something like 2/3 or more. And so this was a very compelling idea. And in this article, Atul Gawande talks about the Camden Coalition in New Jersey, which really focused on comprehensive integrated care for a subset of people with the greatest needs. And so this idea became very compelling. And a bunch of people, across North America got excited about this, and particularly here in Toronto. The problem, as was articulated back then, was problems with poor access to care and poor coordination. And if you can imagine a patient who's in the community, either stable or at risk of becoming unstable, they receive ambulatory care, typically in a primary care environment, but maybe specialty. Things, start to derail. They go to the emerge. They are admitted to the hospital, often in general internal medicine. And as if they are stabilized, then they may be sent back to ambulatory care for follow-up. They may get home care. Sometimes they are they are not able to live independently, and they end up in long-term care. Irrespective of where they end up, there's a subset of patients whose needs are very great, and that some of them remain stable in the community, and some of them get readmitted to hospital or go back to emerge. And so one of my colleagues, Irfan Dhalla, who's at St. Michael's Hospital here in Toronto, he became enamored of this idea of a virtual ward. And it's something that was designed in the UK and then tested in Ontario, in Toronto, in a randomized trial. And the idea essentially was like, how do we fill the gaps? At the same time, we had received some funding at the University of Toronto to build for a project called Building Bridges to Integrated Care. And it was a kind of an incubator model at the University of Toronto to develop, implement, and evaluate innovative models of care for people with complex needs. So it was co-led by family medicine, medicine, and psychiatry, so already integrating across disciplines. And every project needed to have representatives from community care, primary care, and hospital care, integrating across the community continuum. When we started, it was hard to find a lot of people doing this kind of work, but it did increase over time. When we look at the results, we had received about $7.5 million over a 4-year period to evaluate a series of projects, not operate them. We got 61 applications and 9 projects were selected and implemented. 6 out of 9 were sustained and 4 were scaled up beyond initial sites. One of those models was called the scope model. And I just mention it right now because I would say some of these models became building blocks for other models. The scope model was a classic one where essentially it's a phone number where a family doctor calls one number, press 1 to speak to a general internist, 2 to speak to a nurse navigator, 3 to speak to a community access care coordinator, so a community service coordinator, or 4 to speak to a radiologist. And the idea was, how can we make it easier for family doctors with complex patients and complex needs to get help quickly? So that was an example of one of the studies that was trialed and has now scaled up. And so we had many others. One thing I'll point out is that sustaining 6 out of 9 years later is already pretty good. And part of it was the idea that we funded evaluation, but we wanted to, the institutions had to promise that they're going to carry on with the project. And for them scaling up beyond initial sites, that's like, just under 50%. So, we're relatively happy with that, but it is a complex problem. We'll come back to it. And not all these studies were positive. Actually, many of them had negative results. Some of them had positive results, and some of them, pivoted and modified as they went along. So that was the Bridges experience. The next thing that happened was that in 2014, the Strategy for Patient-Oriented Research at CIHR set up the Primary and Integrated Healthcare Innovation Network. And this was supposed to do a bunch of things, again, work across the continuum, tripartite leadership, so now bringing patients in as well as policymakers. And one of the initial things in the very first meeting in 2014, and some folks on this call might have been at this meeting, they said, we're going to measure your impact based on what percentage of the top 5% you target over time. And so it's 5% of the top, the people with complex needs, and then going to 10% at 5 years and 25% at 10 years. This was a very ambitious thing to ask for. Interestingly, it was dropped and never mentioned again. But I do think it set the stage for some of the work that we did. So in the PICI network, there were a number of projects that address people with complex needs. And I'll just highlight one, PriCare, led by Catherine Hudon, that is currently operating in 3 different provinces and is expanding beyond that to other provinces, but also being scaled up across Quebec. So it's a nice example of a project being turned into a program. And it's a project around case management. And then there's another one called Navicare or Soin à Vie from New Brunswick, which was also a project from PICI that became a program. So there are examples of scale up. There are examples of programmatic development, but it still remains a complex thing. The idea that we started with, that we're going to bend the cost curve by addressing the needs of people with addressing the needs of people with complex needs that are the top 1% and 5% of system users, I don't know that has turned out as a fully fleshed out strategy. And I'm going to let my 2 speakers talk more about that. The last thing I'll leave you with is that health spotting study that Atul Gawande published was then the subject of a randomized controlled trial with over 800 participants, published in the New England Journal. And they found a 62% reduction in 180 DA readmissions in the intervention group, but unfortunately also in the reduction in the control group. So there was no difference between intervention and control. And there's lots of sort of mathematical reasons. When you choose people who are on an extreme, then they often regress to the mean. And I'll let my 2 colleagues talk a little bit about how we analyze this and how we address it. So for today, we're going to start with asking, who are the people with the highest need, and what models might work to help them. So I'm going to hand off to Paul Ronxley to kick us off and really outline the characteristics of the individuals that are in this group. So I'm just going to close this and hand off to Paul. I need to stop sharing, and then I'll let you.
I'll start sharing here. Stuff. Okay, you can see my slides here.
Oh, and Paul, I didn't get to do your intro. Why don't you just introduce?
Sure, yeah. So I'm Paul Ronxley. I'm a health services researcher at the University of Calgary. I'm also the associate scientific director for the O'Brien Institute for Public Health. O'Neill, thanks so much for having me today, and thanks for everyone for joining. I was going to show you some of the work that I've been doing around understanding patients with complex needs in Alberta. And as O'Neill mentioned, I'm going to outline the problem or the challenges. Then Terence is going to swoop in, provide us with some like a path forward, maybe some positive findings in Ontario. So hopefully you don't leave this talk totally deflated about, what we can do for improving care for complex patients. So I'm going to start off with a bit of background and a bit of context. So maybe you've seen this figure before, or at least you've heard of it. And you know that the amount of money that we spend on healthcare continues to increase every year. And this is a figure from the Canadian Institute for Health Information. And you can see from this black dotted line that we spent around $350 billion on healthcare in 2024. So a huge amount of money. Where do we actually spend this money? So it's about 25% on hospitals, 14% on drugs or medications, and another 14% on paying physicians. And so you can see at the bottom, these three buckets have grown over the last year. And there's also these price tags attached to each of them. And so it's, roughly $2,000 per patient for hospitals, $1,000 for drugs, and $1,000 for physicians. And you're probably thinking, well, I don't spend that kind of money on healthcare. And that's because, as O'Neill mentioned, healthcare spending is unequally distributed in the population. And there's this concept called the Pareto principle. Maybe you've heard of it called the 80-20 rule before. And so this holds true in a lot of different scenarios. Maybe if you're a business owner, 80% of your sales are going to come from 20% of your clients. If you're a hockey fan like me, and you're in a hockey pool, you'd want to know that 80% of the goals come from 20% of the players. The same holds true for healthcare. 80% of costs come from 20% of the population. And as O'Neill mentioned, there's research in Ontario that shows that 5% of the population use 65% of the resources. So the questions become, who are these patients and why do they cost so much? Like, how are they accumulating so much healthcare spending? But more importantly, what can we do about it? And so that's what we're going to be talking about today. So what do we know about this small group that costs a lot? So there's in the medical literature, there's lots of different terms that are used for this subgroup. And as O'Neill mentioned, sometimes they're called high users, sometimes high cost patients, high needs, high cost patients. And I recognize that it's not a great term, and no one would ever call themselves a high cost patient. But for the purpose of this talk, I'm going to use this convention from the medical literature. And there's previous systematic reviews that have described, high cost patients. And there's a few points that are consistent across the literature. First, that they make up the sickest and most complex part of our population. Often their healthcare use is driven by hospitalizations, emergency department use, and it's often a result of multimorbidity, so multiple chronic conditions, plus or minus underlying mental health conditions. They're a very diverse population as well. And they vary across healthcare settings. I'm going to show you that what you see in acute care is often very different from what you see in primary care. And it differs by context and also the healthcare system that they interact with. And there's one key thing that I think a lot of people agree upon is that we need tailored interventions to meet the needs of high-cost patients within our population. And this is the big challenge. We've known about high-cost patients for decades. O'Neill showed that New Yorker article from 2011. It's been almost 15 years, and policymakers are still struggling to move the needle to find solutions for this problem. And there's no shortage of research in this area. There's lots of complex interventions that have been tested. And as mentioned, some of them show mixed results, some show some positive results, a lot of show negative results in this space. And most have really only focused on outcomes like reducing healthcare costs or maybe reducing healthcare utilization. Very few focused on other important outcomes like patient engagement or quality of care. But what is clear is that there's not going to be a one-size-fits-all approach to addressing this problem, and so maybe we have to start thinking of this in a different way. And so where do we start? And maybe if there's not a one-size-fits-all model, maybe the question becomes, can we identify subtypes of high needs, high cost patients and group them into maybe more homogeneous groups that are amenable to targeted or personalized interventions? And this is an area that I've been working on for the last few years. So I'm going to show you a bit of work in that space. So I work in Alberta. I use population level data. It's called administrative data. I use, it comes from a number of different sources from Alberta Health Services and Alberta Health, and these include things like the population registry, prescription drug information, ambulatory care information, which gives us information on emergency department use, discharge abstracts data, which is hospitalization records, physician claims, even laboratory data. And I use all of these and put them together using a patient's healthcare number to get a picture of their interaction with the healthcare system and how that changes over time. And I have a team of analysts that are much smarter than me, and they have experience analyzing these huge data sets. And for the work that I'm going to show you, we use this statistical technique called latent class analysis. And it's a way of basically uncovering hidden groups within data. And you can use this to kind of let you to understand who's likely to be in the same group based on probabilities and maybe characteristics that are similar or different across these groups, or in this case, classes. That's why it's called latent class analysis. In this case, we identified a cohort of adults that were persistently high cost. So this is the top 1% of healthcare spending for 2 or more consecutive years. So then we ran a latent class analysis in this model, or in this group of patients, using a number of different variables that are available within administrative data. And so in a roughly 4 million adults in Alberta that lived in the province for 2 or more years, we identified about 22,000 persistently high cost patients. And we found 9 unique subgroups in this population. First one I've labeled cardiovascular disease. It's mostly heart failure, patients with heart failure. The second one, patients with rehabilitation or recovering from complications of surgery, patients with severe mental health conditions, namely schizophrenia, advanced chronic kidney disease, patients that require dialysis, people with autoimmune conditions requiring expensive biologics, patients with dementia, waiting community placement, COPD, so chronic obstructive pulmonary disease, certain treatments for cancers, and the last one being unstable housing situations and or substance abuse. So these are the 9 groups that we identified, and we published this paper in CMAJ Open a few years back. But what you'll see is that the majority of these costs in those 9 subgroups that I just showed are driven by hospital spending and drug spending. So what does this look like if we focus it on primary care setting? So here's we followed a similar approach, basically identifying persistently high cost patients within primary care, so top 1%. And we used cost again as a proxy for healthcare use or need, focusing on the top 1% that were there in primary care spending for 2 years or 2 or more years, and then use this latent class analysis to identify the hidden subgroups. What we found here, again, in that 4 million adults in Alberta for 2 years, about 22,282 persistently high needs, high cost patients. The average age was 53, 63% were female, and the average number of primary care encounters per year was 30. So a huge amount of healthcare use. You know, I think for most of us, we'll use primary care once or twice in a year. This cohort of patients using 30 times per year. Cumulative spending, $1,400 per year. So not a lot of money overall. If you think about that in terms of total healthcare use, that's 1 day in hospital. So it's not a lot, but it's a lot of money within a primary care setting, so to speak. So what are the 5 groups that we found here? And so our latent class model identified 5 subtypes. I've got them listed at the top here. And I've got different names. I don't think these are great names, but the first one I've called it the worried well. Probably not, I'd be interested to hear what others would think would be a better name for this kind of moving forward. We've got the worried well group, complex chronic disease patients, patients with underlying mental health conditions, CKD, and poorly attached patients in rural area. I'll just kind of show you a few of the different features of each of these. So this first one here, the worried well group, was almost half of the cohort. And in this case here, they're a lot younger and very low prevalence of morbidity relative to other groups. The second one, the complex chronic disease patients, older cohort, much higher morbidity, high use of specialist care as well. The third one, mental health, high proportions of homelessness, unstable housing, high prevalence of alcohol misuse, depression, schizophrenia. CKD, of course, this is an older cohort, high levels of kidney disease. And the last one, poorly attached patients, so 60% living in rural areas, a very young cohort, so an average age of about 40, and very high use of the emergency department, which maybe suggests they might be using this as a main source of care instead of primary care. Here's a bar chart just kind of showing the total healthcare use across those 5 subgroups. So primary care is in the bright blue, and that's at the bottom of these stacked bar charts. You can see that it's a very small proportion of their overall healthcare use in this setting. When we look at the actual total cost for these groups, of course, the complex chronic disease group resulted in the highest cost overall, followed by the worried well, the mental health group, and then CKD and the rural patients. So I think of this as a starting point to help us understand the key subgroups that are high users of the healthcare system and within primary care specifically. But of course, there's a lot of limitations to this kind of data-driven approach. First, we focused on adults, and we know that there's unique high-cost profiles in pediatric populations and youth populations that aren't included in this model. And I've shown you there's 5 groups, but they're not mutually exclusive. So that suggests that one intervention may not meet the needs of like one specific subpopulation. People can also move between classes over time. So you don't just stay in one of these subgroups. As you age, or maybe you develop different health conditions, you'll move across these subtypes. And as I'd mentioned, it's a data-driven approach to understanding this population, which has its problems. It's only as good as the data that you can put into the latent class model. So there's limited information that we have in admin data on social determinants of health. And if we had that type of information, we'd probably highlight different subgroups than what I've shown here. But I hope I've shown you that you can use administrative data to maybe start getting at who are the unique subtypes of high-cost patients. I've shown you 9 in the overall healthcare setting, and then 5 that are specific to primary care. This might be a starting point to help us understand, the specific populations and tailored interventions for specific subtypes. So I'm going to leave it there, and I'll stop and basically just have Terence reflect on if these subtypes ring true with what he sees in clinical practice, and then more importantly, what can we do for pathways for these different complex patients? So thanks so much for your time, and happy to answer questions once you've heard from Terence.
And I can see people putting comments in, so carry on putting comments and questions, and we'll hand off to Terence. And maybe Terence will briefly introduce you, or general introduction.
I can do this, but I think
Go for it.
so. Thank you so much, Paul, and thank you so much for inviting me to the discussion today. I am, as O'Neill said, I am actually a general internal medicine physician at Trillium Health Partners, and a clinician scientist at the Institute for Better Health. So you heard from Paul about from a research perspective about this issue. I'm going to bring a more of a clinician perspective and also from a clinical programs perspective. And some of these things that we talked about have not been researched much, so we'll just keep that in mind. I'm also not a primary care clinician. As an internist, though, we do see a lot of patients with complex needs, and I hope that this brings a useful perspective as we carry on our discussion afterwards. So dive right into it, because people are here from all over Canada. So just so that everyone's on the same page, I work at Trillium Health Partners, which is a healthcare organization located in Mississauga, Ontario, the city just west of west of Toronto. We are the only acute care hospital in the whole city, but we also serve part of West Toronto as well. The population in Mississauga is very diverse. Our Ontario Health team has a large achievable population of more than 900,000. And as you can see, many chronic conditions are prevalent in our population. The organization itself is large. We are a large community teaching hospital with more than 1.7 million visits per year, more than 225,000 emergency or urgent care visits, more than 68,000 admissions, and we give births to more than 8,000 infants every year. But the organization has a strong desire to kind of address needs of complex patients, mostly because there's growing demands for healthcare that we may not be able to meet. So this is a graph produced by the decision support team at the hospital. The red line represents what the projected demands for inpatient beds are over the next 10 years. And the bottom blue lines tell you what the expected capacity we have to deliver this care, even with major infrastructure build coming on, in the next 8, 9, 10 years. But even with all these infrastructure builds, there will still be a gap. So if we don't do things differently, this gap likely will persist, and that's kind of what motivated us to think about what ways can we do things differently and address some of the complex needs that patients have inside and outside the hospital. So I want to talk to you about something called a solutions clinic, which is, as an intern, this is the internal medicine type intervention. It's actually started by one of my colleagues, Dr. Sean Chug. As we emerge of the pandemic, which, after what happened over the past few years, there is definitely a desire for specialists in acute care partners to kind of support other sectors, including primary care and long-term care being two of the most with prevalent needs. But trying to implement change with like a group of 30 physicians is often challenging. So Sean has the idea, what if we create a small group of clinicians who work, who knows that what they're getting themselves into, and willing to experiment different models of care and see what we can build. So there are 4 of us who currently work in this clinic. We still actually rotate to this clinic, one of us per week, that sort of thing. And we continue to provide acute care services like taking care of inpatients, as well as being the internist in the emergency department. So we still have the breadth of kind of scope of practice, understand what's happening in the system. So the model of care is continuously being evolved, and this is what it is currently. So I want to highlight some of the things that we're doing. We continue to serve the hospital sector, but also have streams of work that work with primary care, long-term care, and as well as the community care medicine program as well. This may seem like a busy slide, but compared to the journey that patient with complex care needs to navigate, this may not be that complex. And I'm going to start from the bottom of some of the interfaces that this clinic, which is staffed by 4 internists, operate Monday to Friday, 8 a.m. to 4 p.m., what we do. So I'll start from the bottom. So we partner with the long-term care sector. So there are 14 long-term care homes in Mississauga that we partner with. These homes know that we exist and we're ready to help. And basically, we are providing internal medicine consults whenever the long-term care home thinks that there is a need for it. Could be chronic conditions with multi-morbidity that needs managing beyond the scope of the MRP, or this could be some acute issues. We usually see these patients within the same day. So what would happen is long-term care home identify a need for consult, they contact our clinic, and we schedule interaction, usually in the same day. And we do this virtually so that we can actually respond quickly. In these encounters, the long-term care staff is always present. So depending on the home, sometimes it's a nurse practitioner, and sometimes it is the nurse, and sometimes when the physician may be present. Then we also have the opportunity to interact with the staff as well as the patients, and if the caregiver is present as well, we can interact with them. From experience, we get a wide variety of issues that we can help with. Sometimes about chronic management of things like difficult to control hypertension or interactions with medications and diabetes and that sort of thing. But there could also be acute issues like we think this patient just had a seizure last night. We didn't send them to the emergency department. What should we do now? That sort of thing. So that's kind of one way we support the long-term care sector. Moving up from the bottom, the next program I want to tell you about is a community paramedicine program. So these are actually frontline paramedics who are very experienced, and they went on to get additional training to become community paramedics. So when they work as a community paramedics, they're not answering a 911 call at the same time. But these are people who are capable of and have done it for many years. And they get their client source from a number of sources, both like from hospital or not from the hospital, even during other ambulance calls when patient not transported to the hospital. But the firefighters or the paramedics recognize that this person's at risk. They may come back for visits. They really work with the patients and the caregivers as well as local supports. Like they may have supported housing programs. They may have work with the primary care physicians, try to improve, like try to prevent hospital transfer and deterioration in the community. That's kind of their goal. There are actually we don't get involved in every single of these patients, but there are times when the community paramedicine team think that the internist will be helpful, and that's when we get involved. I must say that from a internist perspective, we see this as a valuable resources for two particular patient populations that we could not reach before. One is the homebound patients. Sometimes, very often, people with complex needs get admitted to the hospital, and they have very poor mobility. And sometimes we send them home even with a Hoyer lift, making them going out of the house is quite challenging. In the past, we'll say, go see a family doctor, in a week or so after discharge. And chance of that happening is quite small because of the logistics of it. But with community paramedicine, we're now able to follow these patients even after discharge. The community paramedics will actually arrive at the person's house. They could, do a very detailed assessments prior to connecting with us. So they'll take a look at the medications, take a look at the bottles, make sure, they're actually taking the medications the way they are. They take vital signs, there's volume status. They can even do some point of care testing like glucose or that sort of thing. And then they connect with us over video. And the paramedics are there, and we are on the other end, and the patients and the families are also on the other end as well. And we're able to actually, assess and make recommendations through that. We try our best to kind of not disrupt the usual circle of care, like to make sure that primary care doctors always know that we have done something. But we'll talk more about some of the challenges in doing that as well in these contexts. But that's one population we find the community paramedicine team to be highly effective. And the other population is people experiencing homelessness. So for example, I've met a patient through the community paramedicine program where the person had recently had a hospitalization at a hospital with heart failure, and he has a grade 4 ventricle, got this, and also have chronic kidney disease, and got discharged home with furosemide. And then the person did not follow up in our clinic like we had scheduled appointments for. Community paramedicine team was able to connect with them in a parking lot. They got in touch with them, they earned the trust, and able to we actually have a assessment over video, and the person was was in the parking lot, but that's okay. We are able to have a talk about what are the challenges of them coming to the hospital, but we can even renew medications, do point of care testing, that sort of thing, to kind of try our best to support the care needs while working out the issues. So those are the two populations we find through experience that community paramedicine programs are quite helpful in that way. And then walking up from the bottom again is the primary care sector. We also are able to support primary care with rapid referrals. We usually see them within the next few days. So when there are issues, often, there might be unexpected results, we don't know whether to send to the emergency department versus not. So we can sometimes get involved and we're able to see these patients quickly. So I remember one example is, I think one of the patients, a primary care physician, reported that they weren't feeling that well. And so routine blood work, it turns out the hemoglobin was quite low. The family didn't really want to go to the hospital for a number of reasons, and we're able to connect the same day with the patients and the family. In that case, though, we don't always prevent hospital admission. Even though, the family physician is wondering whether we could arrange outpatient transfusion, we could definitely do that. But in that situation, we thought that the right thing to do is actually get the patient to the hospital because we want to figure out where the patient's bleeding from, which would be difficult by just giving them transfusion and not doing additional investigation like endoscopy. So we don't always prevent hospital transfer, but sometimes this is what patients need, and we think that's the right thing to do. And also, like as O'Neill mentioned at the beginning, there's also the SCOPE program that was implemented. Internal medicine is not the only service, but if a primary care clinician's call the scope line and does want to talk to an internist about the patient, we do actually return a call within the same day as well. So, and of course, we continue to provide service to the hospital to help with post-discharge follow-ups, both on the emergency department as well as the hospital side of things. So hopefully this gives you a flavor as to how a clinic like this can adapt to evolving models of care to provide more support for patients with complex needs. From an operational perspective, not from research perspective, we do kind of keep track of, service planning. That's our purpose to see what we're actually doing and what are the outcomes when we get involved. So as internists, we often assess the patient, investigate, diagnose, treat. We get to expedite tests sometimes because of our connections with the hospital system. We sometimes refer to other people too, like services and subspecialists as well. But as you can see in the community pain medicine program, most of the time we make changes in medications. A lot of the time we follow up and see how things go over time. And not infrequently, we actually said nothing else needs to be done. Some reassurances that's needed. And of course, we also do sometimes do investigations, referral specialists, and even the emergency department when needed. And then, so we also collect data about the long-term care visits that we do through the clinic as well, and we have more experience with that. And as you can see, it's very similar. Referral to ED and specialists is relatively low on what happens on the right-hand side of the graph, but most of the time it's changing the medication, investigate, follow-up, or nothing needs to be done. So that's kind of what we do. The middle graph here kind of crudely tells you, what kind of issues we're involved with, and you can see the point of this graph is really that we get involved with like a lot of things and not really one particular thing. So sometimes I make a program design of how to support patient complex needs is actually important, right? So the bottom right here, not sure how well you can see, we actually have referred 99 people to specialists, but when you take a look at which specialists we refer them to, like most of them is one person to this, like only like there's no specialty that we have referred more than 6 people to, for example. So developing very deep models of care where, where a lot of disease-driven models, sometimes maybe this is one of the reasons in reality where, it may not work well from a people with complex needs perspective. And also, like I said before, there's a lot of, other factors too, like whether they're homebound, with the mobility status, and the housing situation also affecting some of these interventions. In the interest of time, I won't go through some of these things. But just reflecting, like through as a clinicians and a researcher with some knowledge about what happened in the system, like we feel that actually one of the key facilitators to this kind of model is actually a relationship that's built. Often people work in their silos. As an internist, I now can talk to primary care physicians, and so that even though like when next time I discharge a patient, the person I'm sending a discharge summary to is not just a name. I actually may have to say, oh, I talked to them last week about a different patient. So there's the relationship part that we think is not captured by some of the evaluation about, whether things work, whether we actually avoid admissions, but these relationships are often not captured as an outcome. We also know the nurse-term care partners and the challenges that they face, and we know most of the nurse practitioners in the home by name. Same with the community paramedics as well. And actually, it's very eye-opening for someone who work in the hospital to see what the community paramedics see as well, like through their lens. We also think that maximizing scope of practice of the team is important. When we have calls with long-term care and they have the MRP, that nurse practitioners, we're able to discuss things at a much higher level and just give advice. To actually make community paramedics more effective, we actually now are developing medical directives where they will allow them to actually deliver some interventions like IV furosemide in the home or first dose of antibiotics when we're involved after reviewing with us. And like I told you before, we now feel that we have ways to reach people that we could not reach before. And then a lot of these new models of care require, we can't really design it from the outset and expect what's happened. There's often needs that surface as we interact with patients and our partners, and we have some degree of, problem-solving flexibility in, for example, someone needs a procedure, we can, fit them into a procedure clinic, on Friday, and I can just go and do the procedure myself because I've met them before, that sort of thing. So this is not really within the rules of what we're supposed to be doing, but sometimes having a small group who is willing to innovate can help with some of those processes as well. But there's also, as a clinician, there's also some, some reflection that we have about things that we are challenging and risk. As an internist, like some patients have relationship with primary care, they may have, relationship with the endocrinologist, their cardiologist. Inserting ourselves into this situation sometimes make us think whether we're helping or whether we're further siloing and fragmenting care. So that's something that we are thinking about, but don't have a good answers about, and curious about what people think. As you can see, the needs that we see are so varied. Like, if I make a pathway from street clinic, it may get used once every 6 months, right? Like, so being in the hospital setting where it's a large organization with lots of resources allow us to make this like one-off things that we need to do to kind of help support what needs to be done. And I think listening to Paul said about some of the phenotypes of the high-cost patients, I think as internists, we also realize that we don't help everyone that can refer to the clinic. And maybe some people, like especially if it is a non-term medicine problem. And also there isn't really a robust way for us to address some of the social determinants of health. Some of these experience we told you about is how to kind of reach them, but it doesn't really change underlying structural problems that exist that require more thoughts or some of the reflection. And finally, I think we're going to have a discussion, but we just want to bring in the Learning Health System Action Framework from the Institute for Better Health. I can put it in a chat about some more resources if you're interested in finding out some more. But just listening to Paul, so we just think about the gears within the engine of the learning health system. About like, for example, from the how can we use this approach to think about how we can address integrating care of patient complex needs involving primary care. I think the analytics part is extremely important up here. Even though Paul described data in Alberta, but I think people across the country feel that what's been described is applicable in Ontario and their context as well, in Quebec, in their context as well. And also, we want to remind people that, like the research data is important, but we also in our thinking that like qualitative data from people with lived experiences, as well as like clinicians on the ground, actually offers a lot of insights and actually complements the quantitative data as well. And be sure that we need to think about both. And then moving on to the evidence synthesis gear, as O'Neill had mentioned, people have been working on this problem for like more than a decade, and there are some successful solutions. So we can implement what have been implemented elsewhere, like the SCOPE program, as incorporates part of solutions. And of course, the biggest gear in the learning health system is a co-design. And the reality is that often we do not get to design things from the beginning. So now there might be these solutions clinic happening. And when you see this data from what Paul has presented, so now hearing all that, what do we do now to kind of tweak the existing model to kind of remove parts that don't work, have no value, and how to co-design with clinicians, with people with lived experiences, with community partners, and focusing on equity, reaching those who cannot reach, to kind of redesign our service so that it could have better impact. And of course, just because we design them doesn't mean it will happen in real life. There's lots of things we learn from implementation science. And as well, then once we have this kind of model, then evaluation about whether this works and why it works for home, kind of a realist sense about like why it doesn't work, and and feeding back into the system to kind of further our goals of equity-centered quadruple aim would be kind of the goal. So I'll stop here, heading back to O'Neill, and then looking forward to the discussion.
Thank you, Terrence. All right, and it's a very nice mix of sort of in-depth research as well as application and the agility of clinicians in practice. So I'm going to go to, there's a bunch of questions. People can put up their hands, but I'll start with Walter's question. How do we design group-specific or general quality measures to assess where there are gaps, and particularly opportunities for improvement across or within these groups? So Paul and Terrence, I'll let either or both of you have a stab at this.
I can start if you want, Terrence. I think, Walter, like you've nailed it on the head. This is it's a very tricky question. You can see that even from the people agreeing in the chat that moving forward in this space is really tricky. I think the way that I've been doing it, I think that I've shown you those 9 subgroups, and it's from a research perspective, it's very easy to take these 9 and say I've got 9 programs of research in that space. And I've kind of focused efforts on a group that I work with a lot. It's the chronic kidney disease group. And within that group, we've been kind of focusing on, well, first off, this idea of high users. And, a lot of times we focus on those patients that cost a lot, but really there's only a small proportion of that cost that might be potentially preventable within that. And so we've been using this concept of ambulatory care sensitive conditions, and even that has some contention around it. But really understanding the smaller subgroup within that actually might have some preventable spending would be a good starting point. And then once you identify that group, you could start using qualitative work. And we've been using this critical incident study approach to asking patients that come in to the ED or to the emergency department, do you think this encounter was avoidable? Do you think that there was something that could have been done to prevent you from coming in? And you find some really interesting results when you ask patients and you ask clinicians these types of questions. And I think that there's probably some space in there to start thinking about, was this related to quality of care? Was this related to access to care? And that might be a starting point to identify some specific metrics in this space. I see even in the comments, understanding specific proms and prems in this area might be a good starting point. But again, very tricky to understand if those are specific to people with kidney disease, or are there questions that could be broadly applied to different complex chronic disease patients? It's kind of a non-answer answer, but it's I don't know, Terence, if you want to add anything to that.
So I don't quite know actually. How do you measure group specific? Because all the other thing is people may not belong to one group. Like that's kind of is the other thing, and sometimes there are competing interests and priorities of the person and the care team. I suspect that it will be a combination of like quantitative, like objective measures, but also like understanding other processes such as relationships and care processes that that may need some data collection, that sort of thing. But that's kind of my thoughts. But I don't think I have a good answer to the question.
All right, thanks to both of you. I want to pick up on Catherine had a question here around profiles and targeted programs and thinking about what's generic, what's specific. And Terence, maybe we can start with you. Like you showed a lot of variability in the pathways and the things you do, basically doing whatever works at the moment. Is there anything that generalizes from what you've seen so far?
Yeah, so I think there's so we see that people have many different needs, like clinically. I think as general internists, both in the inpatient side as well as on the ambulatory side. Like if you think about like how to do one thing better, like people sometimes need PICC line for antibiotics. Maybe we should, make sure we put in PICCs more efficiently. It helps, maybe 2 of your 20 people on your list, right? And then some other people need some other thing, and that will help. That other thing that you do will help another 2 people on that list. So I think that's one of the challenge. But there's a way around this though, is that there are organizations with with lots of resources, lots of programs, for example. But if you allow some flexibility of a clinician to do the right thing, maybe that is maybe it is about the relationship, right? Because the reason why sometimes family doctor, we see some patients and refer to family physicians, we saw a patient I think this person really needs something real, need this done. We have relationships with our subspecialties colleagues with the DI department, so we are able to facilitate that. And sometimes it is maybe partly you need a system with pathways, but also with relationship between the people in it, so that it's not, you cannot anticipate all needs, but then when there is a need that needs to be met, that people can leverage relationships and a standardized way of working to kind of address those issues. Maybe one way to think about it.
Yeah, thanks, Terence. That speaks to the generalists in the audience. Paul, any thoughts on this one?
And nothing really to add to that, to be honest, O'Neill.
Okay, let's go on to Sabrina has a question here on insights from the data or the work on composition of teams. And you can see integrated primary care teams are a growing thing, but Terrence is talking about teams that span much more than just primary care. But to either of you, any thoughts on what does the data tell us about what might be worth investing in terms of integrated teams?
That's a tricky one. I know that the work that we've been doing with some colleagues in primary care, looking at the importance of continuity of care specifically. And I don't know if Lisa Cook is on this call and Terry McDonald, but they've been doing some work looking at just clinician, like clinic continuity versus primary care continuity, just from a single provider versus a group provider. And I've actually been showing that in both of those scenarios, it actually seems to be very important when it comes to providing care for patients with complex disease, specifically those with heart failure, COPD, some of the ones that I had shown you as those high user groups. But nothing else from the data that I've been doing specifically at the Alberta level. That was more primary care specifically, but just showing, I guess, the value of clinic continuity as well. I don't know, Terrence, can you speak to more multidisciplinary care within these chronic disease patients as well?
Yeah, so I don't have any data to have any answers for that question about composition of team. Clinically, like we we expand, like the solution clinic work with multiple providers, right? With nurse practitioners, nurses at the front line at the long-term care home, the primary care clinicians themselves, and even paramedics now. Um, and there are different people and different team members, right? So we know that physicians are doing less home visits, right? So for those patients who are homebound, acute paramedicine is providing some insights that that will be helpful to the clinician, for example, and often can flag things for us, and even and coordination among different sectors is often difficult. How to communicate with them is often very difficult, right? Sometimes, so I think there's some of the structural things about how we work in teams, and I think the composition team likely may change over time, as well, about the needs of people, or who can actually fill those needs.
Walter had a follow-up question about this related around looking at other services within the groups. You've got your paramedics, anything more you want to say, Terrence, about, because I think what you're talking about is building relationships so that you can work as effective teams across institutions, right? Anything you're missing or anything you'd want to add to, say, the clinic you're already operating?
So I think we do not have a lot of leverage to address non-medical issues. Like, I think that's kind of as internists, like you said, what we do, we create medications, we investigate, and I and some of the, so I think so mental health being one of the phenotypes of sometimes people apply, or there's a lot of overlap between medical illness and mental health illness as well. And sometimes we feel like we're not actually that well equipped in addressing those issues for the whole, can address the blood sugars, but we're not really addressing the whole needs of the patients. And I think mental health support would be one that I identify with, from clinical experience, would be highly helpful. And also more resources to address some of the social determinants of health would also be highly helpful as well.
Excellent. And there's some in Viv's comments and some of the other comments where there's a lot of talk about sort of understanding how do we build a team that corresponds to the needs. But there's a question from Shelley around navigation and the role of navigators to integrate. Any comments on that?
We have a colleague, Carrie McBrien in Alberta, that's been doing some work around patient navigation in the space of complex chronic disease patients. It's been a very tough trial, I know, for her to recruit for and do work in this space. But I think that the idea of a navigator seems to work for specific subtypes of patients. Again, not knowing exactly that, and I'd love for her to be able to talk to it. But I know that there's work in this space in Alberta. And it would be interesting to have her talk about that at one of these rounds for sure.
Excellent. Okay, so there's one last question from Aza Estad around the Scope Clinic. And maybe Terence, you want to comment? Like, this is, as some of you may have seen on Monday, Ontario has decided that it will attach 100% of its population to a primary care team in the next 5 years, which is an extraordinarily ambitious task. And there is the challenge of it, attaching the patients actually who are, it's a heavy load for the clinical practice to carry. Any comments on any work that's been done to help attach unattached patients, and the type of work that, either Paul, you may be aware of in Alberta, or Terence, the kind of stuff that the Solutions Clinic help us achieve this goal?
Yeah, so I think from a Solutions Clinic perspective, from an insurance perspective, we quickly realize, like, when we interact with patients, that like we are not primary care clinicians, because there are a lot of things like I'm not sure there's statistics out there about there are lots of non-internal medicine problems, and that needs to be addressed. So we have, because I think that's one of the, like, because of where the Solutions Clinic is situated, we have not been too involved in attaching patients to primary care. We do work very closely with a family health team who continues to accept patients who are unattached, especially the ones that we discharge from hospital or identify to the clinic. They have a family medicine teaching unit, so so they often have capacity, and we have been relying on some of those resources to attach patients. But we do think attachment primary care, in addition to specialist care, is absolutely important for the chronic disease management pathway of patients. So.
Sorry if I may add, O'Neill. So my question was about the primary care providers send the patients to the Scope Clinic, right? They sign up, I know the thing, but do the primary care providers who work in walk-in clinics know about the Scope Clinic? Because the way it could work is that it just becomes a side effect of the referral to the Scope Clinic and the Solution Clinic, because they can send the very sick walk-in clinic repetitive visitors to the Solutions Clinic, and then from the Solutions Clinic, we can figure out how they can get attached. So it's just knowing the primary care provider's location of where they work when they're sending to the Solutions Clinic. So I don't know if the form when they sign up says if they work in a FO, walk-in clinic, etc., because that would be key.
Yeah, thanks for that, Aza. This is going to be a big, work, at least in Ontario, for the next 5 years, but I think across the country. So thank you all for joining us for a very dynamic discussion. Lots of great comments. And please fill out the survey to help us with future sessions. And our next session will feature Shelley Doucette and Ghislaine Rouly talking about both navigation, but also the patient perspective on complexity, and bring that piece of it to this conversation. All right, and thank you all for an excellent session. Have a wonderful day.
Thanks so much, everyone.